Okay, can you see the screen? Okay,
Yes.
perfect. All right, so this is going to be a relatively short didactic unless people have a lot of questions, because we're talking about what happened during the most recent legislative session that is peripheral to substance use disorder treatment in any way. So we're going to look at the bills that actually passed. There weren't a ton of them that relate to us, but we'll review those quickly, and then a couple that did not pass but did get through one chamber, which could be an indication that they will be back in the future. So some of the past legislation from this session included information about fentanyl test strips, some core behavioral health crisis service, new service we're going to have in West Virginia, involuntary commitment, which I am not an expert on. So maybe someone else, I mean, I can give you the highlights about what changed, but that is a very complex process. Auricular detox, and then the state's going to have certification programs for comprehensive behavioral health centers. And then the final piece that we're going to talk about that passed was a pilot evaluation program for residential treatment facilities. So the House Bill 4373, this is an interesting and good bill regarding fentanyl test strips. Different states have looked at this across the country. Prior to this bill being passed, the fentanyl test strips were not defined as drug paraphernalia. So the way that it was treated, I guess, could be different. But the legislature wanted to put it explicitly in code that for harm reduction programs that possess, or individual opioid users who possess actual fentanyl test strips, that would not confer possession of drug paraphernalia, which obviously is good. The legislature was cognizant of the increase in overdose deaths related to the fentanyl that we're seeing in this state and this country. And so they integrated that into the criminal code. So it is not considered drug paraphernalia now in West Virginia. Senate Bill 181, now this is not in place yet. It will take a while to establish, but similar to like we dial 911 when we have a physical, we need an ambulance, we're having a physical crisis or any kind of medical issue, there will be a new rescue line called 988 that's going to be developed in West Virginia. So people dial 988 if they're experiencing, or someone they love or are with are experiencing, a mental health or substance use emergency. So don't have a timeline on that, but it did pass, and we'll see how long it takes to be implemented. Other states, they're trying to nationalize this. So other states in the country have also passed their legislation to approve their Department of Health and Human Resources to start development of that. So this bill, House Bill 4377, about involuntary commitment process, the reason I bring it up because there can be involuntary commitments for substance use disorder. I know it's typically not easy. The process itself is not easy. The one thing that I would just like to say about this is it doesn't go into effect until June 10th. So if this is something that's going to impact your care, then get up on it before June 10th. But basically the big complaint, and they've been working on this for a couple years, is the medical clearance went in the involuntary commitment process that has been taking up sizable chunks of law enforcement's time. They have to go to like an ER and wait with a patient, and the ER clears them, but then getting a bed takes hours or days. And all of that time is eaten up by these law enforcement people. And additionally, it is paid by whatever county or district, whatever the law enforcement district is. So they've been working a couple of years on this. Hopefully this solves their problems. But what it gets down to is the evaluations should be prompt within like 2 hours, their mental health evaluations for commitment. The judicial hearings themselves have to be done within 48 hours, and they can be done by video, as can the mental health evaluations. The blanket medical clearance requirement is no longer in effect. The caveat in the code talks about if someone needs in the bill, if there's suspicion that it is a medical reason causing the underlying psychiatric or substance use disorder emergency, then they would have that done, but it's not a blanket requirement. It also changes a little bit of the standards from the legal perspective to clear and convincing evidence and remove sworn application. The person that would be seeking commitment has to have direct evidence or observation of what has happened. And then in this, they're also going to pilot these alternative transportation methods, so non-law enforcement. And as part of that, they're developing that and developing like criteria for who would be appropriate to be a transporter, which will be interesting because we have problems just getting people transported to medical appointments with COAT. I mean, so supposedly that's going to be piloted in like 5 counties. Mon County is not one of them. But when they come up with this alternative transportation plan, DHHR will be paying for transportation, and there will be quarterly audits done on the effectiveness and safety and all the criteria that they're going to look at for that transportation system. House Bill 4288, this I don't know if anybody's done this. I actually got trained to do auricular detox, but then didn't complete my clinical hours. So I don't do it, but it is a 5-point acupuncture technique that is done for, stress, but also for people in recovery. And until this bill passed, it had specific professions that could practice this. PAs and NPs and RNs and social workers. And I think they even had law enforcement correction officers. And what this bill did, and I think I understand that they were really thinking about peer recovery coaches and how effective they are as a member of our team and our treatment modalities. And so they are allowing the acupuncture board to approve anybody that they deem eligible to be safe to do this 5-point auricular detox acupuncture. And they also changed the definition. You have to be, quote, of good moral character, which a lot of our code section for professionals says that. And it's obviously a very like what is good moral character exactly? So they wanted to make that more specific for this, and have changed it to be free of felony bearing a rational nexus to the profession, to hopefully, again, open that up more to people that might find this intervention effective in their treatment modality. So they'd still have to be approved by the Board of Acupuncture. They'd have to go through the training, get certified in auricular detox, and then they could submit an application to be approved by the Board of Acupuncture to do this. Senate Bill 247 is looking at certifying a state certification of our community behavioral health clinics. And to do this, DHHR is going to have to develop what their certification is, but also get approval from CMS, because this is going to impact payment in a good way if they can develop and get approved this program for which certification will happen. So the Bureau of Medical Services and the Bureau of Behavioral Health will get together and establish this, get approval from CMS, hopefully, knock on wood. And if that does occur, then the payment will include quality indicators in addition to the prospective payment for patients in the health clinic. So more on that to come as they develop those criteria and we hear from CMS. This is really interesting. And after we're done, I would like to hear what you think about these measurement criteria, because I personally think they're going to be difficult. Again, this is going to require a CMS waiver to implement. So DHHR will have to do that first. But the expectation is then that MCOs, managed care organizations with Medicaid, will be able to contract with SUD residential treatment facilities to allow enhanced payment based on performance metrics. Now, all these metrics are not developed yet, but they would all include post-treatment planning and connecting patients to the community support and wraparound services. And so they have to be developed, but they must include these following criteria. They must be able to measure if a patient has been free from return to use. And that even though I put 1 month to 3 years, the measurements are like 1 month, 6 months, 1 year, 2 year, 3 year. So they'd have to figure out how to keep track of that over that period of time after discharge from like a 30-day residential treatment. The patient would have to have housing, again, over like 1 month, 3 months, 6 months, and a year post-discharge. They also expect employment to be tracked and reported, similar to the drug-free criteria as far as timing. And then medical, substance use, psychological, and other community supports have been arranged for these discharge patients, again, from 1 month to 3 years after discharge. Patient has transportation, that's only 30 days post-discharge. They have to account for and report that. And if the patients have needed any additional substance use disorder treatment, and from 1 month to 3 years after discharge. Now, remember, with quality metrics, it doesn't mean that these have to be reported on, and the variable reported has to be, 100%. That with quality measures, they find, or they're supposed to find a reasonable goal for satisfactory. So I think this is really going to be interesting. The MCOs do not have to do this with residential treatment facilities. So I think it's a good premise if it's developed right, and if everybody buys in. And I hope whoever's working on this does it kind of in a full stakeholder group to come up with the best way to meet these metrics. Or, and some of from the federal standpoint, some of the shared savings are, there's no particular goal of like 80% or 90%, but it's on like a bell curve. And the people in the, that have higher achievement take the money from the people that have lower achievement, but you're really competing against each other and not necessarily striving towards a certain goal. So I don't know if they'll work that out this way, but that's more, more to come on that as well. So few pieces of legislation that passed one chamber, but didn't make it through the whole process. An interesting bill about MAP programs and community relations. Again, none of these passed, so they're not law now. Dispensing prohibition on the CSMP, which some of these I wasn't even really aware that they are currently in law, but they are. And then a moratorium on opioid treatment programs that I know Dr. Mike Reynolds was involved in advocacy on that bill. So props to him. House Bill 4516 is a MAT community relations bill. And basically it would require that any existing and future OB MAT programs would have to have in their policies, written policies to measure the impact on which their program has on their surrounding community. And there were kind of like 4 specific things that they would have to include in those policies. One would be they would have to do a class 1 legal ad for public notice. Those are those ads when, something like someone's going through probate and you're supposed to notify the public that this person has died and we're going through probate, so any debtors can file a claim. So that kind of legal ad that we're going to open at such and such address, an office-based medication-assisted treatment program. The policies would also have to include how your program assesses the impact on the community of your site, and specifically on the neighborhood in which the program is going to be placed. So you'd have to have some mechanism to include in your policies of how you were going to measure that. There is a requirement for policies to have how you're going to maintain clean and orderly facility that does not impede pedestrian or traffic. And then finally, your policies would have to include how you identify and maintain communication with the leaders of your community in order to assure good relationships are fostered. So again, didn't pass, but it did pass one chamber, it passed the House, didn't make it through the Senate. I would not be shocked if something like this came back again, but we'll see. House Bill 4585 talks about the CSMP in West Virginia. Again, this didn't pass, but it would have stricken from the current law that pharmacists have to report to the CSMP the sale of opioid antagonist. Narcan. It would have also stricken from the law that the Board of, and this is, I didn't even know that this existed. Maybe Mark can comment on this, but and why it was even in here. But there's a current requirement that the Board of Pharmacy notify anybody prescribing buprenorphine, whether a mono or combo product, within 60 days of the availability of an abuse deterrent form of buprenorphine approved by the FDA. So right now they have to do it. They still have to do that. It's still in law, but this bill would have taken that out of law. And then there is in current law that practitioners can dispense directly to patients controlled substances, but not for more than a 72-hour supply. And they can't do that more than twice in 15 days. That limit would have been stricken had this bill passed. And again, it did not. And then finally, the House Bill 4607, this was one of two bills related to the code section on certificate of need and moratorium on healthcare services. Currently, there's a moratorium, meaning even if there is a need, even if the West Virginia Healthcare Authority would determine that, yes, there is a need based on the need definition that they use, there is in code a requirement that there can be none. There can be no additional opioid treatment programs, and that's methadone treatment programs. And this bill would have stricken out the moratorium part of it. So you still would have had to exhibit a need and go through the West Virginia Healthcare Authority to that process to be approved, but they would be eligible to go through that process, because I believe, and maybe Dr. Reynolds knows, I mean, it's a very small number of methadone clinics that we have in West Virginia, maybe 7.
The number would be 9.
Okay, yeah, I knew it was an odd number and I knew it was small, but so, again, I do believe this one will definitely be back. So we'll pay attention. It did not make the special call, The special session started today and should finish tomorrow. And that's an add-on because this was the last slide. There was a final bill that does relate to substance use disorder treatment related to the prescriptive, and this passed today at 2 o'clock, passed the House at like 12:30, 2 o'clock in the Senate, has to be signed by the governor, but it will be because it was on his call. And it removes some of the current language in PA and nurse practitioner APRN law related to Schedule 2 and Schedule 3 drugs, which of course Suboxone is a Schedule 3 drug currently, until the governor signs this bill. And if we were not in COVID, and we're still under emergency orders in COVID, but before all that happened, APRNs and PAs could prescribe the way the law was written is they can prescribe 30 days with no refills of Schedule 3 medication. But the way the Board of Pharmacy has interpreted that is, doesn't matter how many days that you prescribe, you can never do a refill. So if I wanted to prescribe a new patient a 7-day supply, but he was going or she was going on vacation, and I wanted him or her to get one refill in 7 days instead of getting a 14-day supply all at one time, under current law, I could not have done that because I would have been allowed to do no refills. This bill that passed today, House Bill 214 was the name. It was in the regular session, House Bill 4111. It removes all that Schedule 3, like no refills. It's just now federal law that PAs and APRNs have to follow. And it also allows for PAs and APRNs to write for 30 days of Schedule 2 non-narcotic and 3 days of Schedule 2 narcotic. Previously, which just passed last session, it was 3 days Schedule 2 period. But that was really to speak to and address. There have been, particularly during COVID, a lot of needs for stimulants for ADHD in children around the state, and there's been some rural areas that it's been really hard. As you all probably know, to get into psychiatry, it can take months. So for people that are competent psychiatric NPs, for example, to treat ADHD in children, that will give them 30, they can write a 30-day supply. But for the narcotics, the opioids, fentanyl, Percocets, that kind of stuff, we can write 72 hours worth. So that is breaking news. Any questions?
Thank you so much. That was a really great overview. Really appreciate it. I'm sure that took a little bit of time to gather. I see that you have unmuted Dr. Hirschler. Did you want to make
Yeah,
some comments?
I was just going to say, I think it's interesting that the government is getting involved in how we incentivize people who provide addictions care. And, in mental health and addictions, we're kind of incentivized to keep sick people around so we make money. And, I'm not sure that's the goal really. So we want to create healthy people and we should be incentivized to do that. So somehow we need to work on how do we finance this whole business. So I like that bill about looking at, I'm not sure that's the right way to go, but moving in that direction is encouraging.
Totally agree. Hey, Mark, can I ask you a question? What is that deal in that CSMP code about you all have to notifying prescribers of a deterrent or abuse deterrent? Like, has that been in that code section a long time? And what was that, like pre-Sublocade, pre-injectable? Like, what was that about?
So, my people, Tom, why are you on this call? Close your ears. Actually, open them up. You already know what I'm going to talk about. All right, so I was just on an RX Summit, and was anybody else at that last week on Hotlanta? A lot of the stuff they actually went over today, Tony. There was some things covered, like the drug paraphernalia thing, and how states are coming around to that, and all that stuff. We in healthcare tend to have, we're a little bit behind in times, and typically street chemists are significantly ahead of us, at least when it comes to my realm of pharmacology, with the sole exception of buprenorphine. For whatever reason, we seem to have our heads wrapped around that puppy a lot more than street chemists. Perhaps because it's not street chemists, it's just diversion and all that kind of stuff. It's a controlled substance. These things happen. We all know that. We've talked about that before. So I've had conversations on a federal level with folks talking about how ludicrous it is as far as the pharmacological aspects of that naloxone within Suboxone. It's 2022. I think we can say Purdue and Suboxone and not get in trouble. And those two ladies are recording this thing, so pharmacologically speaking, the naloxone is not going to be expected to do a whole heck of a lot as far as abuse deterrent. In fact, it's not even really technically approved as that. The package insert literally says that people can and will abuse or misuse the product via IV. And it's because the magnetism, little pharmacists like to call it the opioid mu receptor affinity, the magnetism to the receptor is less than half for naloxone compared to buprenorphine. Meaning that when that product is misused, abused, whatever, and injected, it doesn't really stand a chance. There will not be displacement. They might win the race. Where I'm going at with that is, like I opened up with, is we know that. We should know that. We all know that now, after this pontification at least, that's expected like that. The problem is that the streets don't know that. And conversations I've had even with DOJ, these are the things I can talk about because it's not involving individual things. They've said, yeah, that's great, Marco, but the street price is still through the roof for the solo ingredient product, and that's where the demand is. So that's where we have to react. And I have to respect that. I don't really like it, but I get it. My rebuttal to that is, can you put me out in the streets and educate these folks? It doesn't matter in the products. So as far as that board of pharmacy thing, I wouldn't take too many kidney punches to our wonderful pharmacists in our state and beyond. It's status quo. We have that. It's not just stigma. It's beyond that. Education is larger than stigma, and sometimes stigma is larger than education. It's that they overlap, and that's an attempt to say, oh, patient XYZ is coming into my pharmacy and you have a prescription for Subutex. Whoa. Laura, you already provided weeks ago the 6 references on the pregnancy thing being a, come on, let's catch up with like 2010, now another decade. It's very common, and it still is. And from what I have observed, that is driven by folks outside of healthcare that just don't know that yet. I don't know if we want everyone to know that. I don't know in the end, but that's a lot of probably entirely too much. Sorry, you did ask though. As
I
far
did
as
ask. Yeah, no, I appreciate it.
It's just a tough question that typically ends up in a circular thing like most of these that gets nowhere. And it comes down to just respecting the pharmacology. So I appreciate you asking, either myself or Tom, in that accord, and so many others on this call that actually understand and get that. It's archaic. It's like those other things that you said hot off the presses with methadone or whatever. And now, oh, if there's limits on, I was a little confused on the whole C2, C3 narcotic terminology there, but that's just me. But the whole 3-day, 30-day thing, and it's like, oh my gosh, if you just say it's for pain, here you go, have a bottle. But does a senator understand that? Does the folks you're hanging out with down there? It's tough. I don't even know if I answered your question.
No, you did. You did. Yeah. Thank you. Thank you. I figured it was something like that, not exactly that, but thank you for the insight and the history of that. Any other questions? What do you think of those measurements of post-residential discharge? The transportation, that's not a bad one in 1 month. Do you think it's going to be feasible? I just know from gathering GIPRA data in the grant stuff that we do, it's really hard. Are any of the Sheena or Andrew, do you think it's going to be feasible to be able to gather data on in 3 years on if someone has employment and someone?
Absolutely not.
Yeah,
I think it's going to be so difficult. Tracking down people 3 years from now, if they have, or you just said 30 days for transportation, but 3 years, I mean, we have trouble just tracking them down 10 days. So 3 years is going to be, I can't imagine that.
Yeah, that's what I mean. I don't do that data collection that you all do, but I know that there are struggles, and I know even tracking down nurse practitioners that graduate from W School of Nursing and finding out where they got employed is hard. So I can't imagine 3 years post-residential discharge finding some of it.
Oh yeah, we can't even track down once they're actually discharged. They don't answer their phones. Their phones are probably thrown in the trash. They weren't even, they were burn our phones. So yeah.
If the
Good luck with
government's
30
involved,
years.
they can look at Social Security, and see, are you putting money away for Social Security through a job?
Yeah, I mean, if they use third party, so that's employment. I mean, that would,
Yeah.
I don't know who's going to hold the responsibility of finding it, though. It sounds like it's going to be Center for Hope and Healing to report those to the insurance companies. That's how it works for Medicare shared savings. But I mean, I think it's a really, I like the idea of quality measures. I really think they're great, but I just hope when they do put this together, they have people that have actually tried to track different data and can have, something that's workable and implementable, and not just something, because we do a lot of this in this state and everywhere. We come up with these ideas, but then they're never implemented because it's not possible to implement them, but we just then throw it away and not tweak it. So I hope that this works out.
Maybe the managed care organizations could give the money to the patients who report back instead of the programs.
It's an interesting concept.
Do some contingency management.
Right, contingency management. So yeah, a little element of that. All right, well, thank you, everybody.
Any further questions or comments? Michael, I see that you unmuted, Dr. Reynolds.
Oh, just in case my mouth opens up and noise comes out. I was gonna say thank you.
Yes, absolutely. Thank you so much. No worries at all. It's a very interesting conversation. Well, if you have any questions, please do reach out. We don't mind reaching out to the correct parties to find that answer for you. You're going to get some minutes back, a lot of minutes back today. So enjoy the weather. Next session is May 9th with Dr. Husted, and he's going to be discussing stigma. So we will see you guys then. Thank you again. Bye-bye.
Thanks, everyone.
Thank you.
Thanks, Tony.
Bye.
Bye.